Thank you, Sheila, and good morning, everyone. The diagnosis of a dry eye in a patient with an eye like this is not a very difficult problem if you're using vital stains. The definition of a dry eye today is that it is a multifactorial disease with significant patient symptomatology, ocular surface damage, hyperosmolarity of the tear film, and inflammation. We broadly categorize this entity into a tear deficiency and an evaporative group, and we have flow charts that tell us about the various processes that occur on the surface in the inflammatory subset. We have also worked out fairly well the various factors that lead up to a dry eye and the various pathophysiological processes that occur on the ocular surface in these eyes. The Deuce report has given us various signs and symptoms that can help us categorize the severity of this disease. They have also given us a menu of the various treatments that are available, and they have attempted to dovetail these treatments in a stepladder manner according to the severity of the disease that we're treating. So that, in essence, actually finishes my talk, because this nicely summarizes the approach to a dry eye. However, as we have understood more about this disease, various implications have arisen, including the recognition that we are dealing with several distinct subsets of patients. For example, a 70-year-old elderly postmenopausal lady and a 30-year-old computer professional who sits on a video display unit all day long in an air-conditioned unit both have dry eyes, but they are different. Similarly, a post-surgical situation and somebody with an underlying systemic disease have differing contributory factors applying to the dry eye. If you look at the dry eye itself, we understand that there can be various subsets. There can be dysfunction of the aqueous component, the meibomian glands, the mucus and the epithelial surface. The lids can cause problems because of evaporation or because of tear stasis and inflammation, and conjunctivochalasis can add to the complexity of this problem. The solution then, therefore, may be optimizing the tear function in these patients in order to give them relief. And in order to do that, we can titrate a variety of situations, and we'll deal with these in turn. The main treatment strategy still remains tear supplementation, and we have a wide variety of tear products that we can use for this. And generally, we use them until we reach a frequency of 6 to 8 times per day. When this does not suffice, we move on to tear preservation using either a punctal or an intracanalicular plug. For those patients who can't afford these relatively expensive devices, we can create a raw area around the punctum and use a conjunctival patch to achieve the same end results. Tear stimulation in the Indian context is with oral pilocarpine, which we use at 5 milligrams 3 times a day to produce more tear output. For those with problems in tear composition and this kind of a distressing filament formation because of mucus precipitation, temporary relief can be achieved with the use of acetylcysteine drops, but a more permanent solution requires holistic attention to the ocular surface. With aqueous component, we understand it's not just the quantity and quality, but also the tear turnover that is important, and you must pay attention to this in somebody with a dry eye state. Most of these patients will also have anterior and posterior lid margin disease, and this must be managed appropriately. Tear stasis is a rather poorly understood phenomenon, but does cause significant inflammation in patient symptomatology, and management will require the use of soft steroids. We also understand today that the tears in a dry eye patient are hyperosmolar, and this can cause desiccation of the epithelial cells and death. And therefore today we have available drops with organic solutes which can counter this hyperosmolarity phenomenon. In somebody with a very severe dry eye, you can perform a lateral tarsorrhaphy, as this helps to optimize the ratio between the existing tear volume and the exposed surface area. Because we use tears plentifully in these patients, one must pay attention to the toxicity from the preservatives, and if one does not have recourse to unpreserved tears, you can consider using the transient or disappearing preservatives like purite and perborate in the drops that these patients use. When the dryness exceeds critical levels and there's a non-healing epithelial defect, you can try the use of autoserum tears because these contain biological elements which can help the surface heal. Lid structure and function are increasingly being recognized as being important, and particularly in those with Stevens-Johnson and dry eye, the undersurface of the lid margin may be keratinized, and this can cause significant corneal damage. And if you recognize this, you can address this with a labial mucosal graft to the lid margin, creating a more healthy and gentle lid wiper which can protect your cornea. People with dryness and a surface like this often have conditions like ocular pemphigoid with an underlying immune component, and in these people, in addition to the topical therapy, you will also need systemic immunosuppression. General measures would include paying attention to the systemic medications that the patient is using, attention to the workplace environment, and omega-3 supplementation. Androgens, although they have shown promise, still remain on the research table. If somebody has a dryness that is like this, with severity that exceeds the ability of medical measures that we just spoke to deal with it, we can still offer some hope for vision to these patients with the keratoprosthesis that we use, and in this particular instance, an osteoodonto keratoprosthesis. So this kind of summarizes our approach to a patient with a dry eye. Unfortunately, if you're talking about a patient with dry eye symptomatology, the situation becomes slightly more complex, because a wide variety of conditions other than just a dryness can result in the same clinical presentation of a red irritable eye. And when you're faced with these patients, it is important to first list the various diagnostic possibilities that can be operating on the patient's ocular surface. These could be conditions that affect his ocular surface, and as you can see, there's a wide variety of them, including conjunctival shrinkage syndromes, superior limbic keratoconjunctivitis, medication toxicity, and the mucus fishing syndrome. There can also be non-ocular causes related to the environment that he works in and convergence and accommodation issues which can result in a tired and irritable eye, which can be commonly mistaken for a dry eye state. And very rarely you can have ocular problems which are more sinister and therefore highlighted in red, which can also initially present with a red irritable eye and on casual examination can be mistaken for a dry eye state. So when faced with this multitude of problems, it makes sense to have some kind of an algorithmic approach to these patients when they're present in your clinic, and you could kind of ask them if they have constant symptomatology. If the answer is no, and if your examination does not reveal any positive findings, all you would need to do is to prescribe tears on a PRN basis. If on the other hand your examination does reveal significant findings, or if the symptoms are constant, you can ask the patient if itching is the predominant symptom. If the answer is yes, and if you do see the presence of conjunctival pigment on the bulb or conch, you're probably dealing with vernal conjunctivitis. If the pigment sign is negative, and if he has other allergic states like the skin, you could be dealing with atopic keratoconjunctivitis. If these are not present, you could then move on to asking him about the timing of his symptoms, and if he feels worse in the morning, and if a tear evaluation reveals a decrease in function, you're probably dealing with an aqueous tear deficiency. In somebody who wakes up feeling worse in the morning but has normal tears, the lid status can be examined, and if there is laxity, you're probably dealing with a nocturnal lagophthalmos or a floppy eyelid. If these are normal, or if the patient is worse in the evening, you look for the presence of lid margin disease, and if this is present, you would treat either the anterior blepharitis or the posterior meibomitis. If these are not present but is still worse in the evening, look for lid laxity, and if this is present, you're probably dealing with tear stasis. And if the lid is entirely normal, you look for the accommodation and convergence, and in people who feel worse in the evening after a work day, these may be weak, and then you can send them to an orthoptist. If these are also normal, you look at the work environment, and if there are some things there that are not right, you can fix that. And if this is also negative, then you think about the more expanded or more sinister indications that we saw earlier. So to conclude, the dry eye is a fairly complex entity. It has multiple coexisting morbidities, and recognition of these comorbidities or factors is quite important. Fortunately, we do have multiple treatment pathways that we can use to help these patients, but choosing the appropriate pathway will often require an algorithmic approach like the one that I just shared with you. Thank you very much.
Thank you, Dr. Rao.